Welcome, Professor Untch. The AGO State of the Art meeting from the German Breast Cancer Commission was presented on the 27th of February 2021 virtually. And could you please comment on the most important changes to your guidelines compared to last year?
Dear Renate Haidinger, we know each other since more than, I think, 25 years or so. This is the first time that we have an interview in English. Thank you so much for inviting me, having me. And well, if I go back to these last 25 years, indeed, it was also a quarter of a century of guideline commission work, which is done by us, more than 40 members from Germany, on a very, very, let's say, independent basis. We are not paid for it. We do it free of honoraria, but it is always a real challenge to try to interpret evidence from data, from studies, and put it into a guideline. A guideline doesn't mean that it is something you have to follow strictly, but a guideline at least tries to drive our physicians and the patients into the direction what kind of treatment, what kind of diagnostic, what kind of therapy should be chosen. And obviously, there is a clear recommendation grading. So if you see a double plus, that really means that that should be done. If you have a double minus, that means, oh, please don't do it. It can harm you. And if you have a plus minus, it simply means that the evidence from data is not so good that we can give it to all or recommend it to all our patients, but in individual cases, it can be done. So if we try to recapitulate all chapters, probably we have to do it more than 4 hours, because it took us this year more than 40 hours of guideline commission work, which was then presented on Saturday. And I will try to focus in some key aspects. And if you are missing any topics, just remind me. So let's start with, well, I'm not calling it prevention, but I call it the recognition of risk groups. And we know that about 10%, 5 to 10% of our breast cancer patients are coming from families who have higher incidence of different cancers. If it is a breast cancer, ovarian cancer family, then obviously the patient should be counseled genetically and can receive genetic testing for mutations. In Germany, we have a very good network of centers who are doing the genetic testing. And what we have learned over the years is that sometimes patients are coming from family who do not have enough members to check for mutations. So it is quite a difficult topic sometimes to say, oh, you are coming, you probably have a genetic mutation and probably you don't have a genetic mutation. But we have clear guidelines for the genetic testing. And this year, for the first time, there was not just the BRCA1 and BRCA2 mutation, but also the PALB2, which was a little bit in the focus of our mutation analysis, because we have learned that those patients who have this, let's say, rare mutation, they still have quite an increased risk of lifetime risk of breast, not ovarian cancer, of breast cancer. And therefore, MRI screening and possibly also risk-reducing surgeries is something which should be included in the differentiated discussion with the patient. So that was the chapter of early recognition, risk factors, prevention. So PALB2, because PALB2 is also going to be a candidate in the testing of different mutations when we are talking about the treatment of our patients who have a metastatic breast cancer, which tests to be done in order to can prescribe a certain drug or a drug class, which we call PARP inhibitors. So until now, we just had BRCA1, BRCA2, which is a clear indication if the patient has metastatic breast cancer, no matter whether she's hormone receptor positive or triple negative, to give her a so-called PARP inhibitor, which is either olaparib or talazoparib, but also the the PALB2 mutation, which goes into the same direction. Now, at the moment, PALB2 is not a plus or a double plus for the recommendation of a PARP inhibitor, but in single cases, when we have a PALB2 mutation, we also can apply to our insurance companies to get this drug for the patients. And I expect more knowledge in the near future, because the basis of this mutation is working in the same direction as in BRCA1, BRCA2 mutated cancer. It's a so-called homologous recombinant deficiency, and that makes the tumor sensitive to the PARP inhibitor drug. Okay, but now that was already to the metastatic cancer. Let's stay maybe in the early or curative setting. And one of the long year recommendation of the AJO Guideline Commission was, and still is, to recommend neoadjuvant therapy, which means you give the therapy, medical treatment before the surgery, then you do the surgery, and then other steps are following. This neoadjuvant therapy is recommended especially in those patients who have a high-risk breast cancer, which is either HER2 positive or triple negative breast cancer, or the so-called luminal B cancer, so it means hormone receptor positive cancer, but who has an additional increased Ki67 or the multi-gene assay telling that it is a more aggressive hormone receptor positive cancer. And the recommendation for neoadjuvant therapy is based on two things. Number one, we know that the tumor in the breast and in the lymph nodes respond quite well to these therapies which we are giving. And number two, if there is tumor left in the breast or in the lymph nodes after the optimal neoadjuvant therapy, then the post-neoadjuvant therapy is switched or changed accordingly to the biology. Like for HER2 positive cancer, it's TDM1. And like for triple negative breast cancer, if the patient has residual disease, then it's the addition of capecitabine, of Xeloda. So this is guiding us very much. Number two, very interesting discussion in this year's guideline commission was the extent of axillary intervention after neoadjuvant therapy. So we really had, I think, quite a hard time to give a very complicated slide as a recommendation to our physicians and patients. But to make the story, the long story, a complicated story, very short, we have seen that we can de-escalate surgery in our breast cancer patients, especially in the axilla over the years. So at the time when we first met Renate, I don't know, 25 plus years ago, it was a standard to do a full axillary node dissection. This is not anymore the case because today, as we all know, we do the so-called sentinel lymph node biopsy, taking out maybe 1 or 2 or 3 lymph nodes and leaving all those other nodes there. For the neoadjuvant treated patients, meaning those patients who have this kind of disease, we are treating first with medical treatment and then with surgery. This kind of de-escalation of the axillary surgery is also a very, very important topic because we don't want to do too much surgery to the patients and just harm them. Because after surgery in the axilla, as you know, you can have edema, you can have pains, and so on. So we try to reduce it. So what we know today is if we have an involved lymph node before the neoadjuvant surgery, and this is something which the patient probably also should know and the physician, because I think patients are regarding to us not just from Germany, because if you do it in English, probably you go international with this. with this forum here. So it is quite important to follow some standards, which I personally have introduced since many years in my breast cancer center, but it is not always the case in other countries. So if you have a neoadjuvant treatment, and I see so many patients from outside of Germany who are coming to me because you are doing this kind of neoadjuvant treatment, it is quite important to put a clip into the tumor so that when you do the surgery in the breast, you can find the tumor or the tumor bed. And also, if you have an involved lymph node in the axilla, meaning this lymph node is suspicious by sonography or by palpation, then you have to take a biopsy from the lymph node and place a clip or a tattoo or some other device so that you can find this lymph node at the surgery. And then when you do the surgery, know that about 40% of the patients have a complete remission, meaning that the tumor cells are disappearing. So you take out that lymph node, you take out the sentinel lymph node, and we call this procedure targeted axillary dissection, and then you can leave all these other lymph nodes inside if those 2 or 3 lymph nodes are not involved. It's a very simple story I'm telling here, but it took us really years of research, and at the moment, many of the patients should still follow a study which I think also Brustkrebs Deutschland is supporting, called AXANA. So this study is following this patient with this kind of procedure. So that was to the surgery. So the motto today in the year 2021 is still de-escalation of surgery. So less surgery, better life quality for the patients.
I think a very important improvement for the patients. You are right, 25 years ago or 20 years ago, it was always all nodes that were found in the axilla, and now it's much more better for the patients. Were there any other changes in the early breast cancer setting?
Yeah, I was waiting for your comment on the multi-gene assays or your question. So to stay with the motto of de-escalation, after the guideline recommendation 2021, we have in Germany the very luxurious, I call it a luxurious situation, that we have 4 multi-gene assays to be paid and to be recommended by our commission, to be paid by insurance companies. It was a hard way, as you know. It took years and years to convince the so-called GBA. But now, of today, the patients in Germany, the breast cancer patients in Germany, can benefit from this multi-gene assays, which is, I mention it because it's a luxurious situation, because we had also in our Saturday afternoon meeting with Isabel Rubio from Spain, with Fatima Cardoso from Portugal, with Giuseppe Corigliano from Milano. And we know that in Europe, unfortunately, not all the patients have access to these multi-gene assays. So what is it about? There are certain situations in our early breast cancer setting for patients who do not have involved axillary lymph nodes, who have a primary surgery and hormone receptor positive disease, and by the usual clinical and histological criteria, tumor size, grading, hormone receptors, it is not so easy to say, oh, you have an excellent prognosis, you just do 5 years of endocrine therapy and it's fine. So surgery, radiotherapy, and endocrine therapy. On the other hand, if you tell the patients, or majority of these patients, oh, you have to take adjuvant chemotherapy, obviously the patient wants to know, it's a good right, what is my benefit? What is my potential benefit out of the chemotherapy? Is it 1% or is it 30%? And I think this communication is quite important for the patient. And we also have the chapter of communication in our guideline commission this year, because I think at least as important as our medical expertise is the way how I or we give the information to the patient, because the patient, no matter what her education level is, she can understand perfectly if we try to find a simple language and not talk in sophisticated Latin words. I mean, I talk to a patient representative and you know what I'm talking about. So again, multi-gene assays is a test which is done from the tumor in the pathology, and then the pathologist can tell us, or the multi-gene assay can tell us, this patient has no increased risk, so therefore we don't have to give chemotherapy. And this is obvious, quite reliable in patients who are postmenopausal, so roughly those patients who are over 50. Now, in patients who are less than 50, the so-called premenopausal patients who still have menstruation, the topic is a little bit more complicated because we still have to look for ways how we can spare these patients from chemotherapy. Because with all the multi-gene assays we have seen from different studies, which are MIND-ACT and RxPonder and so on, we know that the premenopausal patients can have, even if they have a, let's say, quite low risk, they have still a chemotherapy benefit of about 5 to 6%. And I think this message has to be delivered to the patient, and the decision should be made by the patient. If I tell a patient your survival expectation from all our features from the multi-gene assay, 10-year survival is, let's say, 92%. And then the patient is asking me, what is my clear benefit from a chemotherapy? And I tell the patient, well, your benefit is 2%. Well, then the patient can tell, yeah, but that means that 98 out of 100 patients receive this chemotherapy for nothing and have just the side effects, and that is correct. And maybe if the patient has even some additional risk factors like diabetes, coronary heart disease, hypertonus, then obviously her risk of having side effects is even higher than the benefit from the chemotherapy. And this is how we have to deliver our information to the patient. Obviously, if she has a risk, or if she has a risk reduction, let's say by 10 or 15%, probably most of our patients will decide to have the chemotherapy. And we had this discussion before. If the benefit is roughly 5 to 6%, then it's still the decision of the patient. But I think, at least my experience is, most of the patient will take the burden of chemotherapy even for an increase of survival benefit of 5 to 6%.
That's certainly true. That's my experience as well. Some might even take it for 2%, even
Absolutely.
though they have other risks as well. But I think it's a matter of, can I cope with not having had chemotherapy when the breast cancer returns as a metastatic setting? And I think that's something the patients are thinking about, if they can live quietly and quite normal life, knowing they didn't took the small chance on top or not. I think that's the main thing.
But we should keep one in mind. I mean, I'm not, hopefully not, I'm not going to be the chemo guy when somebody is going to watch this video, because I'm not the chemo guy. But I opt for really open communication with our patients, because I repeat it, independent of the education level, our patients do understand what we are trying to deliver them as an information. And probably it is not done by one single discussion. I tell all my patients, you know what? Just go home, take your time, don't decide it today. Talk to your relative, talk to your friends, talk to your physician, whatever. And if you still want to come back with additional questions, please come a second time. I just want you to be very sure about your decision, period.
I think that's a luxury situation for us again in Germany. In other countries, the physicians have a maximum of 2 to 5 minutes for the patient to discuss treatments. So, but even then, it's important.
Renate, can I interrupt you? I mean,
Yes.
because I have seen data from San Antonio, I was shocked to see data from San Antonio patient under radiotherapy, adjuvant radiotherapy, that those patients, or no, their physicians, did not know a iota about their side effects during the therapy because simply they were not seeing the patient during the radiotherapy. Now, this is a catastrophe, sorry, and that has to be changed. And I hope that patients watching to this video go back to their doctors in their different insurance system and say, wait a minute, I'm the patient, I'm in the center, I want to have a good life quality. Please talk to me. I want to give you my information about my side effects and so on and so on. Sorry for interrupting you, but you see
no problem at all.
You know, my heart is full emotion when I see these data, or to see that, I don't know, 20% of the patients are addicted to opioids after breast cancer surgery because simply the doctors did not take, that was in US, that sorry, US. Because simply, probably these patients were thrown off the hospital within 24 hours and just give them a prescription for opioids, go home, take your opioids. I mean, this can addict you to opioids. Please, please, please don't do that, okay?
Yes, I think it always has to be looked after if it's still really necessary, or if other pain medication can be taken instead of, right? Okay, so let us move on to, we talked about the post-neoadjuvant setting. We had data for anti-hormonal therapy during the last year. Is there anything that changes praxis?
So let's start with the good things. In patients who have HER2-positive disease, who receive optimal neoadjuvant treatment, meaning the treatment is given before the surgery, then the surgery follows. If those patients have still tumor cells in the breast and or in the lymph nodes, those patients who have HER2-positive disease are then switched to another drug, from trastuzumab, pertuzumab, to another drug called TDM1. Now, again, we are in the lucky situation in Germany that this is paid by the insurance companies, and hopefully in other countries watching us, this is the same situation. I don't know. Number two, in patients who have triple negative breast cancer patients, the same applies. We recommend patients to have capecitabine, Xeluda. Now, in the quite large group of hormone receptor positive patients who are receiving neoadjuvant therapy, and if they have residual tumor in the breast or in the lymph nodes, we have performed a large international study called Penelope B. Now, Penelope B was presented in San Antonio by Professor Sibylle Leubel and is now under publication, and it also entered, the data also were entered into our guideline commission. The expected statistical analysis of this study was not met, meaning that we hoped to see an effect of the CDK4/6 inhibitor, so cyclin D4/6 or palbociclib, in addition to the standard treatment, which is endocrine therapy. Unfortunately, this was not the case, but these kind of studies, and there's also a subgroup of patients who in the Monarch E, so it was a similar design with another CDK4/6 inhibitor called abemaciclib, and another study also with palbociclib called PALA study. So we have seen in our Penelope B study that in those patients who have hormone, who are in the premenopausal status, so they still have menstruation. If the patient receives GnRH analogs and ovarian suppression, plus an aromatase inhibitor, there was quite a very good effect on the outcome of the patient. And not just this data, but also data from other studies led us in our German guideline commission to change our statement of treating premenopausal patients with hormone receptor positive disease, meaning that these patients, if they have a higher risk, so I'm not talking about a tumor of 1 centimeter, G1, hormone receptor positive and negative nodes. But if the patient has 4 positive loads, a tumor of 3 centimeter and more, a G2 or a G3, and her Ki67, the growth rate of the tumor cells, is higher than 20%, well, those patients have a significant benefit from the suppression of the ovaries after the chemotherapy. So after the chemotherapy is finished, many of these patients, even after years, can return to premenopause. That meaning that the chemotherapy doesn't kill the ovaries, and the ovaries are producing again hormones. And by blocking these hormones with ovarian suppression, by the drugs which we call gonadotropin releasing hormone analogs, in combination with an aromatase inhibitor, the outcome of these patients is better. And therefore, either the GnRH analog ovarian suppression with tamoxifen or with aromatase inhibitor is the better way to go, especially in the younger patients, those who are younger than 40, for example. So this is new. This is new.
Was there also a difference if the partner was tamoxifen or an aromatase inhibitor?
Okay, Renate, now this is the major point at which we both end up with the so-called split voting. I'm I'm from the, so we had a split voting in our expert gremium. I'm from the fraction who argue for the combination in this situation, high-risk breast cancer patients, high Ki67, premenopausal, who argue for GnRH, so ovarian suppression, plus aromatase inhibitor. Because even if the data are retrospective, so we don't have prospective data, but we have retrospective data from prospective study, we see that the more aggressive the tumor is, the higher the Ki67 is, the more they have a benefit from this combination compared to GnRH, so ovarian suppression plus tamoxifen. So again, your clear question was, my personal opinion, better combine ovarian suppression with an aromatase inhibitor. If I go with the guideline commission, then it's a split voting. So meaning that I still have colleagues who say, well, but the side effects of the aromatase inhibitors is higher and tamoxifen is less side effects, so let's go for tamoxifen.
Well, nowadays we try to collect real world data and so on. Would that be an opportunity to find out which is better?
Absolutely, absolutely. Real world data are badly needed in this setting. But I tell you, because we are talking when we prepare the interview about delivering messages, and we really should try to avoid the term negative study. Because a negative study in which 15,000 patients participated, Pallas, or 7,000 or 8,000, Pallas, Penelope B, to simply say, oh, these are negative studies. It's not good for the patients who participated. It's not good for the thousands of people who fought for this study, who are getting the data, who are clearing the data, who are doing the statistics, who are doing the follow-up, and so on. That would be not fair. I just say from studies which did not met their statistical expectation, we can learn a lot. So at the moment, from different studies, including the Penelope B, including the Pallas study, we're going to link to pull together data on this group of patients, and also to try to see whether there are any effects of the combination of GnRH analogs plus aromatase inhibitors versus tamoxifen alone. And I am sure, because these are thousands of patients, that we will have some results which can give us more clear answers to this very important question, because obviously combining ovarian suppression with an aromatase inhibitor is also doing more side effects.
Sure. Do you think it could be an option just to do the suppression of the ovaries, of the function of the ovaries?
Well, we had very, we had a lot of studies in the past. And to do an ovarian suppression of the ovaries in premenopause is better than doing nothing. in hormone receptor positive patients. But the addition of either tamoxifen or an aromatase inhibitor is definitely better, especially in those patients who have an increased risk, meaning lymph node positive disease, high Ki67, G3, large tumors, and so on.
Okay, thank you very much. So now we turn over to the metastatic setting.
Okay.
There are new kids on the block, which are already there or which are coming soon. And it's a very, very exciting time, I think, for metastatic breast cancer, that there are new drugs that might change the way of treatment and to prolong life of the patients. So let's start with the HER2 positive breast cancer. What changed?
So we had a patient forum after the guideline commission, and indeed one of the topics included into this patient forum was this title, which you just said, New Kids on the Block. I think it was a band in the 80s of the last century, and they were quite successful. But let's start with this. The more patient we cure, the less patients we have in a metastatic setting, the less we have to care about new kids on the block, which is not bad to have new kids on the block, because if patients have metastasis or have metastatic disease, obviously they want to know their chance to survive, to be cured, or at least to prolong their life. So the so-called new kids on the block in the HER2 positive disease situation are the following. So we have very, very good drugs in patients who have HER2 overexpressing disease, meaning the two antibodies, trastuzumab, pertuzumab. If the patient have received this in the neoadjuvant adjuvant setting, then the next line of therapy is TDM1, so the antibody drug conjugate. And if after the antibody drug conjugate, there is a disease recurrence or a progression, then obviously we didn't have so many chances in the past. Now we have two very, very important drugs, which in US are already available. In Europe, they are starting to be available, at least one of them. And the two are representatives from two classes of drugs. One is called trastuzumab deruxtecan, so it's also an antibody drug conjugate. And the other one is tucatinib, which is a receptor tyrosine kinase inhibitor. So let's say like lapatinib, but better, just to simplify it. And both drugs have shown a very, very nice efficiency in patients in metastatic setting who already were treated with TDM1, and quite a large part of them even had central nervous system metastasis, so brain metastasis, which was a big problem in the last 25 years. But today we know that with these two drugs, and tucatinib is already available in Germany and other countries, trastuzumab deruxtecan hopefully will be available in the next, 6, 7, 8, 9 months. Having these two drugs, or having these two drugs, we can tell our patients that we have still good chances to delay the progression or even significantly increase the overall survival. So these two drugs are really quite interesting new kids on the block. So trastuzumab deruxtecan and tucatinib.
Does this apply for triple positive? I don't know if I really should use this term. I mean, hormone receptor positive and HER2 positive patients. And would you give this the anti-HER2 treatment for them in the first line, or would you rather give them anti-hormonal therapy?
Yeah, clear answer. About roughly 50% of our patients who have HER2 overexpressing, so HER2 positive disease, also have a hormone receptor positive disease, both in adjuvant, neoadjuvant, or metastatic setting. The major driver of the aggressiveness of the disease is not ER-PR positivity, which is the good thing, but the major driver of aggressiveness and biology is the HER2 overexpression. So what we have to target first is the HER2, meaning trastuzumab deruxtecan or tucatinib are the drugs number one to be used. If the patient has a response to this drug, either to trastuzumab deruxtecan, by the way, tucatinib was not used as a single drug, it was used together with trastuzumab and capecitabine. So in this triple combination, if we have a good response and the patient is hormone receptor positive, then obviously we can continue the treatment with, let's say, tucatinib and the anti-hormone receptor positive disease treatment, which is either an aromatase inhibitor or fulvestrant or something else, or the CDK4/6 inhibitor.
So you give the anti-hormonal, anti-HER2 treatment until progression, or do you stop at one point?
Okay, now this is again a question which, if you would ask it to 42 members of the Guideline Commission, the pure academic answer would be, we have no data. We purely have no data. So what you hear from me today is an opinion, okay? But maybe the opinion is also good because I think it's always important in life to have an opinion.
It's a lot of experience also.
Even if it's wrong, the opinion. Okay, now, let's say the patient has visceral metastasis. She had progression after TDM1. She's going to be treated with tucatinib, let's say, plus capecitabine plus trastuzumab. This was a combination. You do this treatment, let's say, for 6 cycles. The patient has a very good response. The metastases are not growing. They're getting smaller. The patient has a good life quality. At a certain point in time, you have to stop at least capecitabine because obviously this is going to give you side effects. It's still a chemotherapy. And therefore, if she is hormone receptor positive and she has a good response to this triple combination, I would take out capecitabine. I would treat the patient further with tucatinib and give her the anti-hormonal endocrine therapy, either fulvestrant or aromatase inhibitor in addition. So do not wait for the progression. This is my opinion. Combine it. Why am I saying this? I can remember there was a very nice poster at ASCO 2020 from Australia. And they had a very good analysis from real-world data, Renate. So, by the way, from real-world data, patients with metastatic HER2 positive disease were treated with a taxane, trastuzumab, and pertuzumab. Okay. A part of these patients did not receive anti-hormone therapy, aromatase inhibitor, and that other part received for the continuation of therapy, as you said. So you are not going to continue this kind of therapy because with chemotherapy, you have to stop at a certain point in time and then you give the 2 antibodies. But a part of the patient did receive the endocrine therapy and a part of the patient did not receive the endocrine therapy, meaning they were treated just with the 2 antibodies. And the survival was significantly better for the combination of endocrine therapy with the 2 antibodies. So for me, it is reassuring that my statement at least is based on some evidence from retrospective data.
Okay, now we have quite a few countries where we don't have TDM1 available, and probably not tucatinib and trastuzumab deruxtecan. Are trastuzumab, is that an option, or if possible, the double blockade?
Yeah. So double blockade is a very, very good option. Now let me tell you something. We had a very nice study from Germany at the time at which the only antibody available was trastuzumab. And that study was called Treatment Beyond Progression, TBP. So when the patient were progressive on the combination of trastuzumab with chemotherapy, the trastuzumab was still given, and then we just switched to another chemotherapy, which was capecitabine. Outstanding data for the patients. So the same system, the same principle applies probably for the same situation in those countries who do not have TDM1. So you have double antibody combination. You give chemotherapy A, and then you have a progression. Just give the two antibodies and just switch the chemo partner, which might be capecitabine, which might be vinorelbine or another drug. This is what I would do. And I talked to many of my colleagues. As you know, I'm born in Romania, so I speak fluently Romanian, so I speak to many of my colleagues in Romania, and they are doing it exactly this way and have very good results.
Okay, thank you. Very important, I think, for countries where not all drugs are available.
Yeah.
So now let's turn to the triple negative. I think that's where a lot of changes came up as well. And it's also about testing. We need to test the patients.
Yeah.
So what is it about for triple negative?
So number one, triple negative disease is something which I personally, as you know, with Brustkrebs Deutschland, we are focusing on since many, many years. And we have done quite a lot of studies. So number one, it's quite important in a curative setting to cure as much as possible these patients. If we have a metastatic triple negative disease, then today we have many more options than we had like 10 years ago. So number one, chemotherapy is still in place. It's important in triple negative patients. But today we also have the possibility of treating these patients with immunological or immune active drugs. We call them T-cell checkpoint inhibitors. There was a very positive, very nice study with atezolizumab, a T-cell checkpoint inhibitor, plus the combination of nab-paclitaxel or Abraxane. And the second study was the Keynote 355, which was a combination of pembrolizumab with different chemo partners like gemcitabine platin or with nab-paclitaxel or paclitaxel. Positive studies. In Germany, we have the combination atezolizumab with nab-paclitaxel available, and probably later this year, we will also have pembrolizumab because it's the same therapeutic principle. And I hope that in other countries, the colleagues and patients have the same possibilities. Number two, if the patients are recurring after this very effective therapy, the big question mark is what comes next. And there is a new kit on the block, by the way, called sacituzumab govitecan. So it's also an antibody drug conjugate against a receptor of the tumor cell called TROP2. It was TROP2. This is quite an effective drug, and we hope to have it available at least here in my country also later this year, because it is effective in those patients who have different lines of treatment, including the so-called immune therapies with T-cell checkpoint inhibitors. So again, quite exciting times for this kind of research and also good expectations for our patients who have triple negative disease.
Is it important for triple negative patients to test the germline mutation?
Yeah, sorry, I forgot something to tell. If you qualify or you just qualify for a treatment with such a T-cell checkpoint inhibitor, either atezolizumab or pembrolizumab, if your pathologist is finding in the tumor and the immune cells, either in the primary breast cancer or in the metastasis, a marker which we called PD-L1. So that has to be tested in order to give this drug. And the same applies for BRCA mutation. If you want to apply the treatment with a so-called PARP inhibitor, we are talking at the beginning of the interview about this, either for BRCA1 or BRCA2 mutation, then we have two available drugs, olaparib and talazoparib. So therefore, the patient should have a germline testing, so from the blood, for these mutations.
Okay, and then
And it applies also for the hormone receptor positive patients who have BRCA mutation, because these patients can also have quite a good benefit from olaparib and talazoparib. And unfortunately, and this is a very good opportunity, unfortunately, the testing rate all over Europe in hormone receptor positive patients with metastatic disease is catastrophically low. It's like 25%. We have to increase that.
very important if it's relevant for the therapies. Right?
Absolutely, absolutely.
And let's shortly go back to the triple negative. If you have PDL1 and you have TROP2 and you have BRCA1 or 2, what are you doing?
Okay, now always these really challenging questions from Renate Haidinger. 8% of our patients who have triple negative breast cancer. So this is really a minority of a minority, but still we have this minority, and minority have the same right to be treated. Now, this minority of the patients, so 8% of the triple negative, who at the same time a PDL1 and a BRCA mutation, what to do first? Now, in the guideline commission, there's a clear split opinion. So meaning, I belong to the fraction who say, I think this patient need to be treated first with a PARP inhibitor. A majority of my commission, and there are quite good reason to have this opinion, say, no, let's treat her with the combination of atezolizumab with nab-paclitaxel. And then if she has a progression after this treatment, then she can go to the PARP inhibitor. What is my reason to think so? My reason is that from the studies which led to the approval of olaparib and talazoparib, we have seen that the earlier we treat the patient with this class of drugs, the better the response is. And I have at least one additional argument which came from a press release from AstraZeneca 2 weeks ago, that the adjuvant, post-neoadjuvant Olympia D study is positive. So in the curative setting, those patients who have a BRCA mutation and are treated upfront or within the framework of adjuvant neoadjuvant therapy had a significant benefit from the addition of the PARP inhibitor. But we don't know the data. These data will be presented at the next ESMO or ASCO. So that would be the latest time this year to have an interview with you, Renate. And I already have one bottle of Barolo from those people who did not believe that this study will be, I'm not saying positive, I'm just saying to meet the statistical expectation, which is a very, very, very good news for our patients.
Okay, thank you. Then let's very briefly talk about the hormone receptor positive, HER2 negative breast cancer. We don't have the big changes there, but I think we still have too many patients that get chemotherapy in the first line.
And I say yes, too many, yes. And we have to change that.
Why do we have to change it?
Well, human beings are not always prone to changes, to rapid changes. They try to be, let's say, in a certain direction and to change the direction just if they really have. So we were so convinced of chemotherapy in metastatic breast cancer over the last 40 years that it really is hard to convince those people that with a simple pill, with a pill or pills per day, you can achieve not just the same effect, you can be even better and have less side effects. So yes, there are still too many chemotherapies happening outside. And I have many of my colleagues in different countries in Europe, in different countries all over the world, who every time I give them the data of studies, before they are quite conservative and reluctant. But you know, if you convince 1 out of 100, this single one has to convince another 1 out of the 99, and that the next, and so on. So this will be like a domino effect. And one day, I'm not saying that we have to completely avoid chemotherapy. I'm just saying that we can postpone chemotherapy.
Okay. What could be the reason in the first line after the diagnosis of being metastatic to receive chemotherapy as a hormone receptor positive,
Yeah,
HER2 negative patient?
very simple answer. Visceral crisis with organ dysfunction, meaning the patient is really coughing. Her liver enzymes are already very bad. So the visceral crisis, but this is so rare. I have seen, I don't know, on my ward in the last 12 months, I have seen maybe, let's say, less than 10 patients with a so-called visceral crisis. And we are treating many patients. We're treating like 500 patients with metastatic disease, newly metastatic disease every year. So I would expect to see it more often. No, it's not so often. But that is the only situation. Otherwise, we can treat our patient with hormone receptor positive disease with the combination of CDK4/6 inhibitors, either palbociclib or ribociclib or abemaciclib, with either aromatase inhibitor or fulvestrant.
But this means for the premenopausal women, they need the suppression of the ovaries, right?
Absolutely. One of the most convincing data of the ASCO last year was the Mona Lisa 7. And in the Mona Lisa 7, we have seen that the combination of that was an CDK4/6 inhibitor, ribociclib, with GNH analog and aromatase inhibitor was much better, even in terms of survival, compared to the standard arm without the ribociclib. And when I went home from ASCO, I compared the data with my own database, and I have seen that chemotherapy is not doing better, is doing worse. So the message is stop doing chemotherapy in the first line for metastatic premenopausal hormone receptor positive patients.
Okay, clear message. Now we go to the second line. There we have different options, not just chemotherapy, right?
Absolutely. I mean, if a patient has had, let's say, in the first line, an aromatase inhibitor, we can switch to fulvestrant. And also testing. If we test the metastatic tumor, the primary tumor or the metastasis, then there's a new kit on the block, the PIK3 mutation, so phosphoinositol kinase 3 mutation, PIK3 is simpler. And if the patient belongs to those 30%, 35% of the patients who have this mutation, we have a new drug called alpelisib, and this is a quite effective drug in those patients who have this mutation, with some other side effects, which we have to discuss with the patient. But still, we have a very good option.
And what about the PARP inhibitors in this setting?
Always. If again and again. Split opinion in the guideline commission, but this is the situation, Renate, in which the guidelines this year in Germany have done the first time so-called algorithms. What to do if. So the patient has hormone receptor positive disease, metastatic disease, and she has a PARP mutation, a BRCA mutation. This is about 7% of the whole patient population. It's not much, but we have to test for this BRCA mutation. Now, my personal opinion is give the PARP inhibitor first, and if the patient is going to recur or progress, then you can still give the CDK4/6 inhibitor with the endocrine treatment. Many of my colleagues, including the Guideline Commission, are saying, no, we should give first a CDK4/6 inhibitor with either aromatase inhibitor or the fulvestrant, and then give the PARP inhibitor afterwards. So again, personal opinion, Guideline Commission, but the good answer, I mean, the good scenario for the patient is that we have for both situations, progress with this, do the next, progress with this, do the other. It's fine. It's quite a luxurious. I would not call it luxurious situation. This is a positive situation for the patient.
Okay. Thank you very, very much for this wrap up of all the different situations for patients, early and metastatic breast cancer, all the different breast cancers. Thank you very much for taking your time to answer all the questions.
Thank you.
Thank you.